La persona que ens parlarà primer és el Matteo Cella. El Matteo Cella està al Departament de Psicologia de l'Institut de Psychiatria del King's College de Londres i també és psicòleg clínic al Maudsley, a l'Hospital Maudsley de Londres. Ell té una trajectòria absolutament vinculada amb la Till Wykes, que molts de vosaltres coneixeu i heu llegit, per tots els treballs, perquè és la pionera en la Cognitive Remediation per aplicar-la en pacients amb esquizofrènia. El que avui li hem demanat és si ens podia parlar no només de l'aplicació de la Cognitive Remediation a l'esquizofrènia, sinó a la psicosis en el sentit més ampli, incloent també el trastorn bipolar, i és per això que està aquí avui amb nosaltres. Començarem doncs, amb la primera ponència del Matteo i nosaltres seurem a baix perquè així veurem millor la presentació i després ja participarà la Kate i obrirem el debat. Matteo, it's your time. Thank you very much for coming and let's see.
Hello everyone. Thank you for inviting me to this wonderful meeting, and it's great to be here in Barcelona, and thank you to the Catalan Society of Neuropsychology for trusting kind of my presentation. I might be able to take some questions in Spanish later on, but in case you want to make a question, I might ask the translator to give me the instant translation. So, moving on to my talk today, I think I can use this to move on. I'm going to be talking about cognitive remediation for people with psychosis, with particular reference to where we are now in the field and where we perhaps want to be moving. So I'm going to start with the present. So where is the field now? And a good way to start is to put us on the same page is to start with a definition. This is a definition that is put together yearly by the CREW meeting, is the Cognitive Remediation Expert Working Group that meets at international conference and reads as cognitive remediation is an intervention targeting cognitive deficit using scientific principle of learning. I'm not talking loud enough. Using scientific principle of learning with the ultimate goal of improving functional outcomes. Its effectiveness is enhanced when provided in a context, formal or informal, of some other rehabilitation support. So this is the most recent definition. The other thing that I'd like to point out at the start of my talk is what CRT is not. CRT is not that. CRT is not one of the many commercially available package that makes claim about reducing the effect of age on your brain, improve your memory, improve your work performance, or make any various claims that are associated to sell a package. One of the most used is the Nintendo Brain Trainer that in fact has been disproved by this paper published in 2010 in Nature by Adrian Owen and his group in Cambridge, showing that on a large scale project that this type of training do not generalize in terms of cognitive enhancement. So you train on a particular task, you train on a particular activity on the training, you get better in that activity, but you don't improve your memory, you don't improve your attention at large, and that doesn't have an impact in your everyday life. So what is cognitive remediation, or what does the training usually involve? Well, I picked out a few of the major elements of it, and one is extensive practice, repetition on the task, errorless learning, some sort of monitoring is important, scaffolding, sort of make the level of the task accessible to the user, and some training program use strategy-based learning. Just to summarize and again talking about where we're at and what is the situation at present, what is the cognitive deficit in people with schizophrenia? Well, it's quite spread across various cognitive domains and is quite pronounced. The sort of ballpark figure is for one standard deviation below the average of the population and encompasses fields like processing speed, memory, attention, executive function, but also social cognition. And there is increasing evidence that this cognitive deficit is not acquired as a result of the illness, but is developmental. So this is a study by Larry Seidman showing that from age 7, you can actually see an abnormal neuropsychological profile in people that are going to go on and develop schizophrenia, is the red line on the bottom, and the blue line represent bipolar disorder. So people with schizophrenia from a very early age seems to have a impaired cognitive profile. And this is particularly evident for some fields that we'll see in a second. Another paper from Gore et al. Just appeared on the American Journal of on JAMA Psychiatry, I think, shows that the developmental lag in terms of cognitive development is between 6 to 18 months. So compared to their peers, people that go on and develop schizophrenia would have 6 to 18 months cognitive lag in their development. And in terms of what is the impact, recent work published by Nectar Lyons group showing, you see at the top a normal cognitive profile or healthy control cognitive profile, then the square straight line shows the first episode psychosis, and the dotted line with circles shows people with chronic schizophrenia. And as you can see, if I can use the pointer, only the domain of working memory and social cognition seems to be affected by the onset of psychosis. So why do we do cognitive therapies? Isn't medication enough? Well, medication is good and in reducing symptoms, particular symptoms, and in preventing relapse, but is associated with substantial suboptimal response in a percentage of the patient population is between 30 and 50%, so it's quite considerable. Medical treatments might be distressing for some people and unacceptable and bear about side effects. There is poor adherence for a variety of reasons, and if you take medication, particularly antipsychotic medication, for a long period of time, you might experience distressing symptoms and side effects that might be not long-lasting. And not last, they have a negligible impact on cognition, and this is a graph showing Richard Keefe piece of research published in 2007 showed the effect on cognition of the major antipsychotic use in clinical practice. So is cognitive remediation effective? Well, Till Wykes has done the most recent meta-analysis, and just jump into the result. It has got an effect size of 0.45 on cognition, and these effect size seem to transfer effectively to functioning, which in opinion of many clinicians is the real outcome of these type of treatments, and to a lesser extent to symptoms. We also know that from these meta-analyses that effects are durable, so at 6 months most of the effect of the treatment is maintained. And this is basically where we're now. This is the presence of cognitive remediation for psychosis. And when I was thinking about what would be the sort of future or where we have to go next, I came up also with my colleagues with some points, and this kind of showed the last few years of research that we've been conducting at the Institute on these to move the field forward. So one potential important aspect would be to how do we improve transfer to everyday life functioning. Do we consider cost effectiveness at all? Is it important? What are the mechanisms of action? Are there new targets that might be useful to consider? And are we in a position to suggest any augmentation? What can we add to cognitive remediation, if anything? So the first of the 5 points is how to improve transfer. Well, what we know from the meta-analysis is that there are 2 types of cognitive remediation therapies. One that is principally based on practice, so you repeat the task extensively, but there is no kind of understanding or scaffolding around producing some cognitive understanding of the task. And there are strategy-based programs that actually provide people not only with the practice, but also with the strategy to bring those cognitive function, improve cognitive function into everyday life. And it seems that the program that employs strategy-based approach have more of a transfer effect, or the transfer better to everyday life improvement. This is the result of a study recently conducted by Christopher Bowie in the States, looking at pairing cognitive remediation with other forms of rehabilitation. And this particular study showed that if you do cognitive remediation and you pair it with skills training, there are the pairing of the two has significantly higher results in terms of work and is it community functioning, the red one, yeah. So by combining cognitive remediation with another sorts of therapy that looks at skills training, these effects are more significantly higher and more durable. Similarly, research conducted by Maurice Bell shows that if you pair work training with cognitive remediation, there are worked at follow-up are significantly higher 12 months after the intervention. On a similar sort of vein, the same investigator looked at where to which people these outcomes transfer most, and people that start with very low function who seems to benefit more by the pairing of, in this particular case, supported employment and cognitive remediation. These are 2 years follow-up, so we're looking at 2 years after intervention, who benefits most, and people with low functioning seems to do so. Thinking about other factors that might influence functioning or improve transfer, there's a recent meta-analysis by Fettis suggesting that social cognition has got higher correlation with functioning, and I've tried to put them on the same scale here, and the red bar shows domains of social cognition and the blue bar shows cognitive domains, so social cognition might be important. And taking up on this message, Linda Meyer and colleague again in the States conducted a study comparing 36 hours of cognitive remediation with equal amount of hours of training but split in 24 hours of cognitive remediation and 12 of social cognition, and the results support the use of social cognition as part of the cognitive remediation, particularly to improve transfer. Okay, let's talk about cost. Why is cost important? Well, it's all great that we do research, we show amazing results, we show brains that lit up, and we show an effect, but if we can't deliver it, we know that we are working as part of a public service because therapy costs too much, we don't do implementation study, all our research, all our efforts goes into nothing. So it is important to strengthen the case of a cost-effective type of therapy so that the therapy provider, the national health system, might sort of buy into it or be able to afford it and know exactly what are the figures behind it. So Thielweik's pioneer in sort of this field and started in more than 10 years ago looking at the cost of care for people with cognitive impairment as opposed to all the other service users. And as you can see from the slide, the inpatient cost and the residential cost are far higher for people with cognitive impairment. This is not particularly to schizophrenia or to psychosis, but in our trust, that is a mental health trust. And this is again a complicated slide to show some structural equation modeling results showing that cognition seems to be the highest correlated factor with healthcare costs over and above symptoms, if you were to consider that as well. Again, this is kind of putting the saving or how much money you can have in your piggy bank if you do cognitive remediation in terms of the trust. This is again a few years back, but you're able to save about more than £2,000 if you combine healthcare costs and societal costs post-treatment follow-up if you compare people that have done cognitive remediation to people that haven't done it. And again, this is something that we've just finished and we got impressed in Schizophrenia Bulletin, is how cognitive change predict some key domain, and I don't expect you to be able to read it because I can't read it. And it's daycare and special accommodation cost. So the improvement associated with cognitive remediation is directly associated with reduction in these two costs. Other question, what is CRT changing? It changes the brain, the cognition, both. Well, my answer to this is I don't particularly mind what it changes as long as it's improving functioning and actually has an effect on patients' life. But if you were to look at some underpinnings of how cognitive remediation works, there's some work conducted a few years back from Klein showing, this is again is non-human studies, looking at how learning produces cortical plasticity or neuroplasticity or cortical reorganization. So they studied extensive practice and how that affect cortical reorganization in monkeys, and they showed that the task can be roughly divided in two parts. You can see up here, phase 1, where there is a steep improvement in the behavior, but there is very little cortical reorganization, and then phase 2, where there is very little behavioral improvement, but that is where the cortical reorganization seems to happen. And this is the underpinning of mass practice in cognitive remediation, or is believed to be so. But a few years later, Blake and collaborators showed that it's not just about practicing, but it's also about having an understanding of the task, or having some sort of cognitive understanding, they describe it, of the task. So just pairing performance with positive reinforcement and improved performance might not be enough. And these are... These are some of the results conducted looking at sort of cognitive remediation and the effect on the brain. This is one of the first by Sean Eak, showing that cognitive remediation has a positive effect in preventing grey matter decay in people with psychosis, and particularly grey matter decay associated with the amygdala, the fusiform gyrus, the hippocampus, and the parahippocampus. I'm so sorry that Raphael recently published on the biological psychiatry, looking for the first time on network of functioning, and they focus in this piece of research on two important network, the central executive network and the fault mode network, but one looking after the sort of executive function type of thing, and the other one at the basal sort of brain activation. And is a particularly elegant study, and I'm incensing Raphael without him being here, so it's even more annoying. But it's a particularly good conducted study because they also test healthy controls, and they what they show in their results is that after treatment, people with schizophrenia tend to have a performance in these two brain networks that align or goes in the direction of the healthy control. So in this respect, they sort of conclude that cognitive remediation is normalizing the sort of brain network efficiency towards the performance of healthy control. And this is again another very, very recent study using a EEG type methodology, and look at the blood flow changes associated with cognitive remediation, and in particular this study shows that working memory improvement and verbal fluency are associated with improved blood flow in frontotemporal region, and this is just to show you where the channels that improve significantly are on the scalp. So talking about new research avenue, what might be important to do next, and again try to improve transfer, try to improve sort of translation into real life, and what about symptoms? Are we giving up on it because cognitive remediation is not meant to be doing anything for it, or there are actually avenues where this sort of treatment might be promising? Well, how does cognitive remediation work? Well, we think what we thought perhaps is that by improving cognition, we might be improving a functional outcome such as cooking. Well, we know that that is way too simple. Thiel-Wykes suggested a model whereby it's kind of getting a bit complex. Therapy provides an effect on cognition, and we know that that's what we want to do, also on functioning, but also on other sort of possible mechanisms that might mediate or moderate the effect. There are possible other boxes that might sort of be falling into that category, but into that model, but we don't know yet. One of the promising one, though, is metacognition. And we know that from a couple of studies conducted a few years ago that shows that on top of cognition, metacognition seem to have a higher correlation with social functioning. So that might be an important one to include. And in fact, we are already including it in our cognitive remediation program. And the M in front of the CRT stands for metacognition, and is in fact the centerpiece of our therapy sort of process. And it kind of focuses on metacognitive regulation and metacognitive knowledge. I won't go very much in detail here because I want to cover other things, but we are already considering this, and we might be able to publish some results soon. And we've actually created a software, it's called Circuits, that I think it should be available in Spanish. Rafael is working on translating it into Spanish. I'm not sure if he finished it or not. But this is based on the idea of the village and sort of people selecting different buildings, do different tasks. And the metacognitive interface has been embedded in it by sort of monitoring goals and looking at strategies, but also with a metacognitive sort of mask. So every time participants start to do a task, there are some prompts for them to consider the difficulty of the task, how long they're going to take to do it, and particularly use of strategy that might be helpful for the task. And some of the tasks are quite ecological, such as sending a text message to somebody by conveying some simple information that you've received on a letter, so it's not completely abstract. The next bit I'd like to talk about is translational neuroscience and how do we make sense of the clinical work in biology terms and the other way around. I pinched this graph from David Carter Cameron publication showing the translational neuroscience pathway, and essentially it starts with sort of neurochemical, and then the next level up is you're looking at brain functioning, then you're looking at some very basic cognitive mechanism, and then some more complex cognitive mechanism, behavior, and then you have your therapy, like cognitive remediation in this case. What's happening in research is that people tend to either focus on the two bottom parts, and this is the kind of hardcore neuroscience, and other people, such as myself perhaps, tend to focus on the top part, the sort of more clinical elements of it. And what is most likely left out is that bit of very simple cognitive mechanism that might provide the translation between the clinical and the neuroscience research. So I thought I'd start to strive to try to include that element into my research, and I came across with sort of this question to start with, sort of how do we define a good translational mechanism? And I sort of consider all that is a known biological mechanism, is clearly defined, is measurable, and it might be measured in animals and in humans, is simple and is relevant for a more complex process, and is adaptive. And then when you think about that in the context of psychosis, well, you want to really have a mechanism that is impaired in psychosis. It might be implicated in the disorder that has got relevance for cognitive remediation, is related to cognition, and has got some clear biological correlates, about neurochemical and functional. And the one that we came about with is reward learning. This is also used as a RDoc, but we started our thinking just about the time when the RDoc came out, and we kind of were confirmed in, we liked the fact that we found reward learning in there. And reward learning is very well understood because taps on the dopamine pathway that we know is impaired in people with schizophrenia, and there is a lot of basic science that has kind of explored this particular mechanism. So the next question we had is, how do we measure reward learning in human? There's a lot of work done on animals and a lot of tasks that are fit for the scanner but not for the clinical assessment. So I happened to meet a mathematician and become interested in some of his work that used computational modeling, and he convinced me that we could extract reinforced learning parameters from a widely used task. There's the Wisconsin card sorting. I presume most of you are familiar with the task, but just in brief, this is a card sorting task. You're presented with this card at the bottom and you're asked to sort to one of these 4 decks according to a hidden rule that you don't know. And basically, when you decide to sort, you get feedback that is either correct or wrong. So you receive positive and negative feedback, and this task is generally thought as a measure of executive function or set shifting, but we did something a bit funky or different with it, and we apply some computational modeling looking at how people adapt their behavior in function of the feedback that they receive, particularly if people that receive negative feedback are quick to shift, or if people that receive positive feedback tend to stay on the same rule. And I'm not going into the detail because probably I'm not going to be qualified and skilled enough to explain any of these, but trust my word, we work hard and we work out that we could extract 2 parameters, reward sensitivity and punishment sensitivity. When I actually came in to be a bit more helpful was when we did a clinical trial looking at how these fare in terms of cognitive remediation, and a recently published paper we showed that cognitive remediation is effective in improving reward learning and punishment sensitivity in people with psychosis. So the last of the new targets or possible targets was looking at symptoms. Well, we know that cognitive remediation has got a limited effect size on symptoms, but perhaps it's because we haven't looked at it properly. And there is emerging literature on negative symptoms, and the relevance of negative symptom is summarized in this quote. Appeared on a recent review that says that negative symptoms are associated with poor functioning and quality of life. The treatment of negative symptoms is a high priority for intervention development. And basically the last bit says that there is currently not very much available out there to help people with negative symptoms, both in terms of psychosocial treatment and drugs. So we sort of came to think about how cognitive remediation might help, and this is not pure speculation because there are some reports out there looking at how cognitive remediation might have an impact on negative symptoms, and this is a possible model. And from my hypothesized model, I was glad to hear that another good piece of Catalan research came about and showed that this is actually how it happened. So cognitive remediation seems to have an effect on executive function, and then that kind of transferred to negative symptom, and negative symptoms seems to be the carrier of the effect on functioning. And this was research done by Aida Ferreni here in Barcelona. Are negative symptom dimension important? That's another piece of work that we've done recently showing that looking at the more behavioral component of negative symptoms might be more important than looking at the expressive. And in this work, we look at the same data using 2 factorial structure of a clinical measure, and this particular factorial structure differs from that one in the sense that you use more behavioral symptoms and leaves out the expressive. So it might do what is actually supposed to do, improve the behavioral element, but it might not improve affect. So is this just a fluke, or is CRT, or can CRT really help negative symptoms? Well, the evidence so far is that there are a few studies reporting positive effect on positive symptom, so perhaps there is a bias there. There's limited study reporting negative symptom at all because that's not a primary measure for cognitive remediation. But is there enough evidence for a systematic study? We think so, and we've embarked on it. I'm not expecting you to go through that, but this is a consort diagram that you traditionally do for systematic review and meta-analysis. And my collaborator, Antonio Preti, has been able to send me some quick results that is just a preview of what we think we're going to find. And this is the effect size. I'm just going to show you the most important point that is associated with cognitive remediation effect on negative symptom based on, I think, 37 studies we have in so far. And we also found a small effect on the duration of treatment. So the longer the treatment is, the more seems to be helpful for negative symptoms. And just to put these into context, I don't want to create any disputes with CBT or anything, but on the left-hand side of the slide, you have the effect on CBT on positive symptom, which is the sort of major target. And if you consider this particular paper appeared on the British Journal of Psychiatry, the effect size of CBT for positive symptoms, this is hallucination and delusion, is about 25.25. And then if you look at cognitive remediation that is meant to be doing something else, improving cognition and functioning, when you have as a byproduct an effect size of 0.39 or negative symptom, I think is pretty good. So we're going to pursue these and hopefully get impressed soon. So just to recap on this particular side, new targets, we have metacognition, it might be an important target for transfer. For translational target, we've looked at reward learning, and for perhaps overlooked targets that we haven't considered so far, negative symptoms. I want to make another sort of point before closing, and is there any point in augmenting and tailoring CRT? Well, I couldn't find very much, so this is going to be brief. But a lot of people are interested in supplementing cognitive remediation with cognitive enhancement drugs. And this is the result of the only study, or RCT study, published so far that compares, explores the use of d-Cycloserine as an augmentation for CRT. So standard RCT design, get people randomized to CRT plus placebo, people randomized to CRT plus the active drugs. And the result seems to be partly encouraging because they show that there is an advantage in the d-Cycloserine group on the auditory discrimination task and on negative symptom, but the only group that improves on cognitive measure, that's what you would expect as part of cognitive remediation, is the placebo group. So we don't quite know what to make of it. And this is, again, another attempt at tailoring treatment on the basis of drug prescription and genetic variant. Again, this is a very specific study looking at results of cognitive remediation on processing speed in people with psychosis, receiving clozapine or other drugs, and then they divided up on the two variant of the COMT genotype, and people with the valve variant on other drugs don't seem to have an improvement in this field. Again, very, very specific, but this is an attempt to try to make things tailor for service users. And again, this is another bit of speculations work that we've done, and we've kind of struggled to replicate looking at the effect of age. So younger people seems to be doing a little bit better than people over 40. This is, again, a very crude measure of age. So I'm just going to draw everything into a conclusion and try to summarize all the points that I've made. So augmenting CRT, well, this is certainly promising. Social cognition particularly is a field that we are all looking at. I know Kate and group is also looking at sort of augmenting cognitive training with social cognition, but also the more sort of functional rehabilitation type of training, like supported employment or work training, might be useful. Some people have been looking at physical education as well. Cost effectiveness, I hope I convince you that it is an important aspect to look at least as part of your clinical studies, to show that you're in a position to deliver, and that makes sense to your healthcare provider to embrace this type of treatment. Well, the results on the brain are still in their infancy, so do we know, or we can suspect they might make some preventive intervention, or CRT might be preventive to some sort of brain deterioration process, and it might also increase functioning. But I think from a clinician, we don't have to lose sight of what is the important element that we're trying to aim, and this is improving people's functioning. Personalized CRT might be early days to do that, but I think with big data, or sort of trying to create international collaboration, we might be able to find out what are the characteristics that might influence the treatment, and then provide tailored treatment to our clients. Cognitive improvement, and we know that now, it doesn't equate to functional improvement. We need to be looking more at mechanisms like mediators and moderators that might translate the cognitive improvement into functional outcome. And finally, there are new targets for intervention that might be promising, such as negative symptoms, but also looking at translational outcome that might sort of link the brain and the behavior. So predicting the future is hard, and I've tried my best to do so. But some people get it right, and I hope I've done a bit of right, or I've said a bit of right in what I said to you today. Thank you for your attention.